Hello, my name is Dr. Christopher Blackwell. I'm an associate professor, acute care nurse practitioner, and program director of the Adult Gerontology Acute Care Nurse Practitioner programs in the Department of Nursing Practice in the College of Nursing at the University of Central Florida. I'd like to welcome you to the second part of a two-part narrated PowerPoint series covering Unit 5, Solid Organ Transplantation for the Adult Gerontology Acute Care Nurse Practitioner 3 course. In this particular unit, we are going to talk about the clinical use of immunosuppressants, and then we're going to talk about specific agents that we use to achieve this. So we're going to have a pretty significant review of the principles of immunosuppression, all right? And many of the key pathways of organ rejection are targeted by today's growing army of immunosuppressive agents. The vast array of combinations of these agents has dramatically decreased the incidence of acute allograft rejection. However, very little ground has been gained with respect to the impact on chronic allograft rejection or long-term allograft survival. Furthermore, with long-term use, the relative non-selectivity of current immunosuppressants can lead to the development of malignancies and opportunistic infections. And that is the unfortunate byproduct of most of the agents that we are going to discuss. It's either going to be significant OIs, malignancies, or both. So optimal immunosuppression as it relates to transplantation is defined as a level of drug therapy that achieves graft acceptance with least suppression of systemic immunity, right? And that's the balancing act. That really is what, as clinicians, we are trying to achieve by suppressing the immune system so the patient doesn't reject the organ, but at the same time, we're not using such toxic levels of drug that the patient has no immune surveillance. And one of the things that is more recent in terms of monitoring this is the CD3 cell count. So you're probably familiar with the terms humoral immunity, which arrives from, or derives, I should say, from the bone marrow, okay, and that's generalized immunity. So you would see that reflective on, for example, leukocytosis. And then you're also familiar with the term cell-mediated or cellular immunity. And when we talk about immunosuppression in terms of organ transplantation and reducing the immune response so that the patient doesn't reject the organs, what we're really talking about is cellular immunity. There are some humoral responses that can occur and complicate the clinical picture in the early post-op phase, but really when we're talking about immunosuppression overall in terms of reducing rejection of organ transplantation, we're talking about cell-mediated immunity. And the CD3 count really is a proxy measure of the degree of immunosuppression. And this is what the CD3 looks like. Pretty cool looking structure, right? Current immunosuppression protocols typically use multiple drugs, each directed at a discrete site in the T cell activation cascade. And transplantation immunosuppression can be either one, pharmacologic, consisting of drugs like corticosteroids, cytokine suppressive agents, and cell cycle inhibitors, or biological, consisting of monoclonal and polyclonal anti-lymphocyte antibodies and anti-cytokine receptor antibodies. I keep getting tongue-tied here. So that again, let's go over that again. Pharmacologic with the agents we're going to discuss, or biological. So our monoclonal and polyclonal anti-lymphocyte antibodies and anti-cytokine receptor antibodies. The combination of cyclosporin or tacrolimus, or Prograf is the brand name, with a corticosteroid forms the backbone of most maintenance immunosuppressive regimens being used today. So in other words, what the patient is going to more than likely be on is cyclosporine or tacrolimus with a corticosteroid. We know from the first lecture that the early post-op period is where the patient that is post-transplant is going to need the most immunosuppression. And generally, high doses of a corticosteroid are used initially to reverse the acute attack on the allograft. Anti-lymphocyte antibody therapy with monoclonal or polyclonal antibodies is used for more severe rejection, or if, for whatever reason, that corticosteroid therapy fails. We learned in the first lecture that about 5% of patients are termed steroid resistant patients, and those patients are going to be the ones that are going to be candidates for either anti-lymphocyte antibody therapy with the monoclonal or polyclonal antibodies, or another type of biologic type focus if the patient is failing the pharmacologic approach. Induction therapy, also called prophylactic therapy, refers to the use of anti-lymphocyte antibodies immediately after transplantation. And this practice is based on the theory that early incapacitation of the immune system reduces the likelihood of a subsequent rejection. So in other words, if we can really knock out the immune response right from the get-go, post-operatively, the theory is that those patients are going to be much less likely to develop complications later on in life in terms of the rejection. So the related concept of sequential therapy was introduced in response to the significant renal toxicity that we saw with cyclosporine. So patients that received liver, heart, and kidney transplants, they would be placed on cyclosporine therapy, and we would see as a consequence significant renal failure issues. So the practice to use antibody therapy for the first 1 to 2 weeks after transplantation has kind of come into the forefront, and that is the period in which renal injury is most likely to occur. Cyclosporine therapy is not used during that period, so instead we start it a little bit later, and the impact of that strategy on long-term renal function is much less clear. But we do know that using sequential therapy did improve outcomes in terms of reducing renal failure in patients post-operatively, in patients who underwent transplantation. The early intensification of immunosuppression is not universally accepted. So some experts do voice concern because of the well-known association between anti-lymphocyte antibody therapy and infection and cancers. And others describe no benefit, greater expense, or the successful use of regimens that avoid this induction process altogether. Intermediate strategies involve the use of induction only in high-risk patients, or the use of just one dose of an anti-lymphocyte agent followed by early evaluation of renal function. So the current general approach is to minimize long-term immunosuppression. So there are various withdrawal protocols that target individual components of the immunosuppressive regimen, like the corticosteroid regimen or the tacrolimus portion of the regimen. And the overall attempt is to decrease the serious complications that occur from prolonged immunosuppression. So things like infections, cancers, renal failures, fungal infections, all those things that we know are serious adverse events associated with immunosuppression. One of the things that we learned in the last lecture was the association with non-Hodgkin's lymphoma, or PTLD, with the use of immunosuppressive agents. Let's overview transplantation immunobiology. So antigen specificity is determined by an antigen binding unit on the surface of the T cell, and this is called the T cell receptor. Once inside tissues or the circulation of the body, antigens are presented to lymphocytes by antigen-presenting cells, or APCs, which are epitomized by dendritic cells. and the APCs phagocytose foreign particles and foreign proteins and enzymatically cleave them into smaller peptides that are about 8 to 12 amino acids in length. And then those peptides are then loaded onto a class of specialized what are called carrier molecules or MHCs. And this MHC molecule stands for a major histocompatibility complex. So we go from a phagocytosed foreign protein on the APC, basically then loaded onto the MHC, which then carries the peptide fragment to the cell surface where it is displayed to the T cell in the host's lymphoid organs. Thus, there are three essential requirements for the adaptive immune response known as rejection. The first is the presence of an antigen fragment or a protein or what we call a ligand at the cell surface of the APC, a receptor that recognizes the ligand, and then finally activation of the T cells. And the reason why this is important, guys, is because the agents we're going to talk about later on in the lecture target one or more of these three requirements, okay? So the overall target of these agents is the adaptive immune response, okay? And that is rejection. After transplantation of the so let's go back a little bit. The only mobile antigens in solid organ transplantation are passenger leukocytes. And these are of donor bone marrow origin that, for whatever reason, unfortunately, are present in the graft, okay? So after transplantation of the solid organ, these white blood cells will migrate promptly and preferentially to those host lymphoid organs using this process that we described through APC phagocytosis, loading onto the MHC molecule, and then finally presentation to the T cell. And these organs are organized heterotopic lymphoid collections, provide the unique architectural structure and cellular milieu wherein factors necessary for progression from an immunogenic environment to a tolerogenic environment are present in abundance. So these factors include the involvement of things like cytokines, other molecules, cell-cell proximity, and homing mechanisms that ensure an efficient response to the antigen. In the lymphoid organs, dendritic cells and other APCs that have captured and processed the antigen present basically present the peptide fragment of the antigen to the antigen-specific TCR in the context of their upregulated host MHC peptide. Okay, so again, this is that that three process that we're talking about here. And then the afferent or effector phase begins with the secretion of interleukin-2 or T cell growth factor and interferon alpha or IFNA by activated lymphocytes. The antigen-specific immune activation and clonal expression is aborted unless there is upregulation by the APCs of accessory cell-bound co-stimulatory molecules that sustain accelerated production of interleukin-2 and foster the secretion of numerous other cytokines, all right, including things like tumor necrosis factor alpha and beta and growth factors and granulocyte colony stimulating factors, all right, which you're probably thinking you remember those from your pharmacology course when we talked about how those are used to stimulate the bone marrow. The sequential nature of the response amplification has been obscured by the use of the term co-stimulatory to describe the accessory molecules, implying that the afferent and early effector phases are simultaneous. The TCR is a cell surface molecule that associates with accessory molecules including the CD3 and either the CD4 or the CD8 cell. The TCR-CD3 complex interacts with the peptide fragment carried by the MHC molecule of the APC, and this complex is stabilized by the CD4 or CD8 molecule of the T cell. The TCR is a cell surface molecule that associates with accessory molecules, like I said, the CD3, CD4, CD8, and this interaction produces the signal that initiates activation of the T cell. And when that T cell is activated, it proliferates a T cell clone that recognizes a particular antigen fragment. And it does this through recognition of the foreign protein of that fragment. So the basis for MHC restricted antigen recognition requires antigen presentation by the APC bearing an MHC molecule specific to the host. The response, so antigen-directed proliferation of that T cell clone is absolutely essential for that immune response to be effective. So the response is driven by a positive feedback loop. T cells that recognize antigen make the potent growth factor, interleukin 2, and simultaneously become responsive to interleukin 2 by expressing the interleukin 2 receptor. This dual synthesis allows the cells to stimulate their own proliferation as well as the proliferation of other T cells, and then lymphocytes recirculate at a rate of 1 to 2% per hour, migrating through all of the tissues of the body. Antigen-directed proliferation of T cell clones, like I said, again, absolutely essential for an effective immune response. Specialized cell surface homing molecules on the T lymphocytes mediate attachment to targeted alien tissues with a special avidity for the endothelial cells of an allograft's vessels. During an ongoing immune response, proliferating T cells recruit many other cell types and immune mechanisms into action. Cytokines and chemokines can attract and activate other leukocytes. So, for example, cytokines produced by CD4 positive helper T cells attract macrophages and CD8 bearing cytotoxic lymphocytes into rejecting allografts. These cytokines also trigger macrophage activation and CD8 T lymphocyte cell maturation, and the resulting multicellular tissue infiltration has traditionally been referred to as a delayed type hypersensitivity response. Cytokines released by helper T cells are also responsible for the activation of B cells, and thus indirectly for the majority of antibody production. Cytokines also upregulate expression of both MHC molecules on tissues and adhesion molecules on the endothelium, and these events aid in the entry and accumulation of leukocytes. Finally, the cytokines will activate distant organ responses, such as the hepatic acute phase response, producing phagocytes in the bone marrow, and the hypothalamic pituitary axis, which produces the systemic signs of inflammation: fever, sweats, chills. Once the antigen is consumed or removed, then the process will downregulate. If the antigen removal is incomplete, then continuously sensitized memory T cells remain and contribute to a stronger secondary response on re-challenge with the same antigen. However, in some instances, if the antigen cannot be eliminated, the immune response can become exhausted, and then what happens is T cells become deleted by mechanisms that are not fully understood, but ultimately result in cell death or apoptosis. Exhaustion deletion in the first weeks or months after transplantation is never complete, but it can be maintained in a stable state by small numbers of persistent donor leukocytes. Molecular insights regarding interleukin 2 gene transcription and the structure of the interleukin 2 receptor have led to what we call interleukin 2R or interleukin 2 receptor targeted therapies. As molecular knowledge has advanced, investigators have gained greater understanding of the workings of many immunosuppressants, and new strategies have been guided by that knowledge and have resulted in attempts to develop site-directed immunosuppression. So virtually every known step of the immune process can be targeted. And so the newer agents, which luckily for us usually carry less adverse events, though many of those are in various stages of development right now. So let's talk about some of the specific agents that we'll see used in patients who undergo organ transplantation. The first class, which is a class that is very popularly used in the post-op phase, is the corticosteroids. And these agents interfere with the production of interleukin 1 and interleukin 2. So if they interfere with interleukin 1 and interleukin 2 production, then the ultimate effect of a corticosteroid is blocking the early steps of T cell activation. There are 5 glucocorticosteroids which are commonly used in transplantation. The first is hydrocortisone, also known as the brand name Solucortif, prednisone, prednisolone, methylprednisolone, also known by the brand name of Solumedrol, and dexamethasone, or Decadron. Because hydrocortisone has the greatest mineralocorticoid activity per unit of glucocorticoid activity, you should already know that based on your pharmacology course you took probably with me, its routine application in transplantation is relatively limited. So hydrocortisone is not going to be one we're going to see used too much. There's really no universally accepted dosing regimen for corticosteroids in the post-op period. Usually what you see is what we already talked about in the first lecture of this unit, but a preoperative dose of 250 to 1,000 milligrams of methylprednisolone may be given, followed by 20 to 200 milligrams a day during the first week. Acute rejection can then be treated with 1 to 3 large bolus type doses of 250 to 1,000 milligrams of methylprednisolone, or by a regimen starting at 200 milligrams a day of oral prednisone, which is then tapered to a baseline maintenance dose over 3 to 6 days. And there is evidence that doses lower than those traditionally used can also be equally effective. So we don't necessarily have to stun the HPA with a ton of corticosteroid. We actually have some research that shows that lower doses can be equally as effective. In combination regimens, steroid doses often can be reduced to 5 or 10 milligrams a day or less, and perhaps given every other day. Prednisone and prednisolone have much less mineralocorticoid effect than the naturally occurring glucocorticoids. However, sodium retention, edema, hypertension, potassium loss, and hypokalemic alkalosis is seen when they're used for a prolonged period of time. An acute adrenal insufficiency can develop unexpectedly if patients are stressed, even as long as 12 months after corticosteroids are withdrawn. And I think I talked about that in your NGR 6172 or your general pharmacology course, that there were some patients who are on chronic corticosteroid therapy that even after a year of therapy cessation will all of a sudden develop acute adrenal insufficiency as a consequence of stress. I don't mean stress as in like I started a new job. I mean like health stress. Corticosteroids continue improved fibroblast growth and collagen synthesis will be impaired as a result of these agents. So unfortunately, they do contribute to poor wound healing. So surgical wound sites and anastomosis sites, these are at increased risk for dehiscence, and unfortunately, gastrointestinal ulceration will tend to heal slowly, and there is an increased risk of perforation and rebleeding of, for example, varices and other ulcerations that may have been present prior to the corticosteroid therapy or prior to the operation of the transplant as well. Spontaneous ulceration of the gastrointestinal tract occurs in about 2% of patients taking steroids, right? And because signs of inflammation are suppressed, the diagnosis of intra-abdominal infections and peritonitis can be significantly delayed. And unfortunately, that can have disastrous consequences because we already know that the overall immune system is going to be suppressed as a result of all the various agents the patient has taken. So if we all of a sudden now have an underlying acute infectious process that is occult, then we miss that, then the patient dies. And that's unfortunately one of the adverse effects of infection that is associated with the use of these agents. Also, over time, these agents can also impair glucose tolerance significantly. So it's often best to use a sliding scale insulin regimen if the patient is receiving large dose corticosteroid therapy. And if they're going to be on long-term therapy, then oftentimes we may have to give them an oral agent or even switch them over from an oral agent to insulin therapy if the patient develops, increasing insulin resistance. This is an example of a sliding scale regimen using a low dose, medium dose, high dose, and very high dose regimen. And we learned earlier in the first part of the lecture that this is one of the instances where tight glycemic control is probably going to be warranted in the post-op environment for these patients. We've learned already that tight glycemic control in the ICU is problematic. It can lead to hypoglycemic events. However, in this particular patient population where we're talking about transplantation and the need for that graft to heal, we want to keep the sugar pretty tightly controlled. We don't want to have a prolonged state of severe hyperglycemia and delay healing and all the other complications that go along with that. Central nervous system effects like mood swings and euphoria are usually self-limited, and they occur at higher doses, which we give when the patient has an acute rejection. Long-term use of steroids obviously can cause bone demineralization and lead to osteoporosis, and atherosclerosis can also be accelerated with these agents, and prolonged administration of these also cause glaucoma, cataracts, and other ocular disorders as well. Soft tissue and dermal changes like fat redistribution, skin atrophy of a moon face, and striae produce the characteristic Cushingoids presentation, and that's what you see here. And I think I've told you the time I had a patient come in that I always joke because it was seriously the smallest penis I've ever seen in my life. Patient came in, had this ridiculous Cushingoid type presentation, these deep purple striae to the abdomen. And I remember I was talking to the physician, and he was really at a loss as to what was causing this patient's presentation. And I laugh about the penis because I had to go in and get a urine sample from the guy. And I remember the urine coming back bright orange, and the guy had this tiny, what I would call button-sized penis, and it was because there was so much gross fat redistribution that basically the fat adipose basically dumped into the pelvis, and it engulfed his penis. It like swallowed his penis. And I remember I went back to the physician and I said, I would get a cortisol level. I said, this looks to me like Cushing's. And sure enough, we got the cortisol level and it came back sky high, and the patient was in Cushing's. Now, to minimize the development of adverse sequelae, most immunosuppressive protocols attempt to reduce the dose of corticosteroid over time to physiologic levels of about 5 milligrams a day or less of prednisone. However, corticosteroid doses must be reduced carefully, and if we're not careful in terms of tapering the dose, you can put the patient into HPA shock and really cause lots of problems. And really the balancing act is maintain adequate immunosuppression and prevent rejection of the allograft. That's the ultimate goal. Okay, cytokine inhibitors. So this is another agent of class of drug that we use. And like the corticosteroids, these also inhibit synthesis of interleukin-2. And interleukin-2 is a potent T cell growth factor, and it's crucial in terms of that activity of the drug in suppressing the immune response. So basically, shutting down T cell growth factor is the mechanism of action of cyclosporine. The half-life of cyclosporine increases with hepatic failure and is changed significantly by co-administration of a large number of other drugs that can increase or decrease serum levels by induction or competition of the P450 enzyme system. So it's essential that cyclosporine levels be monitored regularly, and then we adjust the dose accordingly based on the levels the patient presents with. Recent literature suggests that the AUC values and peak concentrations measured 2 hours after dosing, or the C2, are more sensitive predictors of cyclosporine effects and may be better parameters to use to guide therapeutic monitoring. Okay, so that's another important thing. The first 4 hours after administration of a dose of cyclosporine represents a period of greatest variability in absorption, and so samples should be obtained within that time frame. The time under the curve, or the AUC, values greater than 4,400 correlate well with a low incidence of allograft rejection. So in other words, we want our value of cyclosporine to be greater than 4,400. All right, that's kind of the takeaway point there. The typical dose of cyclosporine is about 4 to 5 milligrams per kilogram given through a daily intravenous dose. The amount can be given in 2 divided doses, each being delivered over 2 to 6 hours. Or some people prefer to use a slow continuous infusion over 24 hours. And the changeover to oral dosing requires a dose 3 times higher, or of about 12 to 15 mg per kg per day. Oral cyclosporine should be administered every 12 hours. After about 1 to 2 weeks, the dosing can then be tapered once the equilibrium within body fat stores occurs. And in many patients, the dose is tapered to as low as 3 mg per kilogram per day by 6 months after transplantation. Liver transplant recipients who have a T-tube which diverts some bile flow require higher oral dosing because of decreased absorption of the drug. All right, I think I talked about that in the first part of the lecture. So necrotoxicity and neurotoxicity are the major problems associated with cyclosporine. Hypertension is also a major issue. Now, luckily, the nephrotoxicity that's associated with cyclosporine is reversible. So we can either taper the dose, decrease the dose, or stop the drug altogether. But it is very common. Up to about 38% of patients will actually present with nephrotoxicity from cyclosporine. Neurotoxicity ranges from minor things like tremors to severe complications like seizure disorder or chronic encephalopathy. And tremors caused by cyclosporine are common, and that may, in and of itself, may not be a reason to discontinue the agent, but certainly it is something that would be problematic to a patient and need significant education. Hypertension occurs frequently and is usually begins within weeks after the therapy is started. The incidence can range. We have some studies that show about 10% will get it. We have other studies that show up to 80% will actually develop it. And they tend to respond best with sodium restriction in the diet. So remember the DASH diet, and diuretics such as hydrochlorothiazide or calcium channel blockers are effective for these folks as well. Cyclosporine is diabetogenic, although analysis of this effect is confounded because obviously these patients are often on steroids as well, so we're not sure if the overall diabetes that they develop is from the actual cyclosporine or is it coming from the steroid therapy, because they're usually on both. Other metabolic effects of cyclosporine include hypochloremic alkalosis and changes in serum concentrations of potassium, magnesium, prolactin, and testosterone. Hepatotoxicity manifested by cholestatic jaundice is also common, and we looked at that term in the last lecture as well. What that slowing of the movement of bile basically results in this hepatotoxicity. Common connective tissue disorders can also occur as an adverse effect of cyclosporine, and unfortunately, it causes distress in patients because they're oftentimes cosmetic. So you can see things in females like hirsutism. Like this patient here has developed like a beard as a consequence of cyclosporine therapy. And you see this usually within about a month, and it can be all the way up to almost half of patients who are on the agent. And then the other problem that we look at is gingival hyperplasia. It's a little bit less common than the hirsutism issue, but you can see it's kind of unsightly. And it can be so severe that the gingival tissue actually overcomes the dentition, which is what you're seeing in this picture here. And probably the other agent you're remembering that causes severe gingival hyperplasia is phenytoin or dilantin, right? Well, unfortunately, cyclosporine causes this as well. Long-term administration can cause nephrotoxicity. Unfortunately, it can be as up to high as 40%, and the lesions will resemble nephrosclerosis, and that's what I got a picture here of a kidney that is sclerotic. And I don't know if this is necessarily secondary to cyclosporine, but that's what nephrosclerosis looks like. Okay, so another cytokine inhibitor is tacrolimus or Prograf, and it's really interesting how they found this agent. It was found because it was a product that was in a fungus that was from Japan, this Streptomyces succubensis. Hopefully I said that right. I don't know how the hell you say it. But anyway, it's a fungus that grows in Japan. So how crazy is it that this macrolide antibiotic with immunosuppressive action was found from this certain fungus? It is approved by the FDA for use in patients who undergo heart, liver, or kidney transplants, and it is an inhibitor of calcineurin. So it's similar in its mechanism of action to cyclosporine. It disrupts signaling via NFAT, ultimately inhibiting the synthesis of T cell growth factor, which we just said that's the main mechanism of action of cyclosporine as well. And so this is a very common used agent, tacrolimus, for inhibiting the immune response in patients who have had transplantation. Metabolism, like that of cyclosporine, can be significantly altered by liver dysfunction and the P450 system. The typical IV dose is 0.05 to 0.1 mg per kg per day. All right. Interesting thing is, if you've got a patient on another P450 drug, odds are it's going to decrease or increase levels of tacrolimus. So we would have to look up and see, if we were going to give, for example, diflucan, right? We talked about how fungal infections often occur post-operatively in transplant patients, particularly liver transplant patients. Then we would want to make sure that the drug we're using is not a P450 inhibitor, because the chances are your patient's going to be either on tacrolimus or they're going to be on cyclosporine. And so we want to make sure that we're not interacting with that P450 system. The drug is given as a slow continuous infusion over about 24 hours, and the oral dose is about 3 to 4 times higher than the IV dose, and it ranges from 0.1 to 0.2 mg per kg per day, and it's administered in 2 divided doses every 12 hours. The maintenance therapy for this drug ranges from 0.0125 to 0.5 mg per kg per day, and that's because there is extreme variability of absorption among patients, and also because patients respond differently to the various doses of tacrolimus. So in other words, a patient might respond to a low dose of the agent just fine, but another patient might need a higher dose to have that same type of response. So lots of patient variability with this particular drug. There's no decrease in tacrolimus dose that's needed when the T-tube is clamped after a liver transplant. You've heard me mention this T-tube often in the lecture, and in this lecture and in the first lecture, and this is what it looks like. So this is the T-tube drainage system here, and this is basically a duodenal drainage tube. Okay, so again, if you close that sucker off, then you're not going to have to decrease the dose of tacrolimus. The toxicity profile is similar to cyclosporine, and that's because they have a similar mechanism of action. The overall effect of cytokine inhibition or calcineurin inhibition that results from shutting down growth of T cells, basically, is what is related to the nephrotoxicity and the neurotoxicity that you see with these agents. Neurotoxicity is the most commonly reported adverse effect of tacrolimus, can be as up to 32%. The side effect can range from mild toxicity like tremors, headaches, paresthesias, and insomnia, all the way up to severe encephalopathy. Usually neurotoxicity is associated with tacrolimus will respond to reduction in dosing, just like we said with the nephrotoxicity with the cyclosporine, but there are some idiosyncratic reactions that require discontinuation of the drug. And this is a pediatric example of encephalopathy associated with tacrolimus. I looked very hard to see if I could find a CT scan of a patient with encephalopathy that was an adult with tacrolimus, and I couldn't find it. The only thing I could find was peds. But this is a good example of a CT scan where you can see some, brain issues going on here, some encephalopathy as a consequence. So, hyperkalemia and hypomagnesemia are commonly noted in patients receiving tacrolimus. So we would manage that as we would any other patient with hyperkalemia. So we might use, for example, insulin and glucose therapy or Kexalate. Chronic hyperkalemia, though, we have to use something like Florinef, which is a steroid which promotes excretion of potassium through the renal system. Hypomagnesemia often requires magnesium replacement therapy. If we're not careful, we've already learned that hypomagnesemia, severe hypomagnesemia, can result in cardiac dysrhythmias and serious problems. Imuron is a cell cycle inhibitor which is used in maintenance immunosuppressive therapy. It really doesn't have any usefulness for acute rejection. With congenital deficiency of the enzyme, thiopurine methyltransferase, which is in about 1 in 300 patients, or with renal failure, accumulation of 6 thioguanine nucleotides causes increased toxicity. So about 1 in 300 patients or patients with renal failure are more likely to develop toxicity, unfortunately. Dose-limiting myelosuppression can occur in about 1 to 2 weeks into therapy. It usually manifests as a pancytopenia and thrombocytopenia with megaloblastic anemia. White blood cell counts lower than 3,000 warrant a dose reduction or discontinuation. There is also a significant interaction with allopurinol. Remember that allopurinol is a drug that is used to manage gouty arthritis. So if a patient is on that particular agent, then we need to be very cautious in using Imuron. If it is used, we need to reduce the dose by about 50%, okay? Xyloprim is an oldie but goodie, but there are other newer agents. Uloric, for example, is a great agent which actually targets the gouty arthritis pathophysiologic process itself. It's the only agent that really does that, and as a consequence of that, we can switch the patient over should we need to. The only thing is, with Uloric, there is a significant increased there is a significant associated increase in LFTs with that particular agent. So sometimes that could be problematic in a patient that's new liver transplant. MPA is more selective for T and B lymphocytes than Imuron, which results in more favorable adverse effect profiles. It can produce apoptosis in activated T cells, and it can interfere with expression of adhesion molecules in leukocytes and lymphocyte recruitment. There is a controversy about whether or not you need to actually monitor MPA levels. I really don't know much about this agent. I tried to look up more information online and some other from some other resources. I couldn't find a whole heck of a lot, guys, about this particular agent. There are mild adverse effects that are associated with MPA, which are mostly GI. Things like nausea, vomiting, diarrhea, reflux, heartburn, constipation, those types of things. Severe complications, including cholecystitis, large bowel perf, and pancreatitis, have been associated with MPA, but there's controversy as to whether or not it's the actual MPA that is the cause of it. Most of those mild gastrointestinal adverse effects are transient and will go away over time. Prolonged symptoms can be managed by either reducing the dose of MPA or by increasing the interval of dosing from twice daily to 3 or 4 times daily. Hematologic adverse effects are rare and manifest as bone marrow suppression. So one of the common things that we're seeing with the cell cycle inhibitors is bone marrow suppression as a common adverse effect. Usually it's going to occur within about the first 6 months of therapy, and it may be dose related, so it might be a sign that this MPA would have to be reduced, and usually you'll see the resolution of that within a week. MPA is effective maintenance therapy for prevention of acute rejection of solid organ allografts in combination with other immunosuppressive agents such as corticosteroids and cyclosporine or tacrolimus. Okay. So it's used to treat acute rejection of renal transplants and in refractory rejection to reduce the use of anti-lymphocyte therapy. In addition, it's been used as rescue therapy for acute and chronic rejection of cardiac transplant situations. And there has been some recent studies that show that combining MPA with sirolimus, that's not a typo, that's not tacrolimus, that's sirolimus, which I think we'll talk about in a minute, to eliminate the need for calcineurin inhibitors, so your cytokine inhibitors like cyclosporine and tacrolimus will reduce the likelihood of the patient developing nephrotoxicity. So maybe in the future, you're going to see this combination approach of this MPA with sirolimus as a replacement for the current regimen of either the cyclosporine or tacrolimus in combination with the steroid. Okay. Did I not go ahead there? Oops, I'm hitting the wrong key. Okay. So sirolimus or rapamune, okay, this inhibits the cellular response to interleukin-2 and inhibits the progression of the cell cycle, thereby prohibiting T cell proliferation. Hepatic metabolism by the CYP3A4 enzyme creates the potential for significant changes in half-life of sirolimus if other drugs affecting the CYP3A4 is also administered. Remember that the 3A4 enzyme is also that grapefruit juice pathway. To minimize the interaction and potential toxicity of these two drugs, sirolimus administration should be separated from cyclosporine administration by 4 hours. So if you have a patient that's going to be on cyclosporine and sirolimus, you would want to separate them by 4 hours to avoid toxicity related to that 3A4 pathway within the P450 enzymatic system. Sirolimus levels should be evaluated about 5 to 7 days after therapy is started, or if you're changing the dose of this drug, and that is to allow steady state dosing. Unlike cyclosporine and tacrolimus, this particular agent rarely causes nephro or neurotoxicity, but you can see a dose-dependent myelosuppression, and you also can see things like thrombocytopenia, leukopenia, and a combination of these things. All right. So you usually see the thrombocytopenia within the first 2 weeks of therapy. Leukopenia and anemia may be a shortly after initiation of therapy, but they're usually transient, they usually go away. And thrombocytopenia and leukopenia are related to the dosing. So if you get a dose or you get a level of sirolimus that's greater than 15, then that could be the reason why you're getting these thrombocytopenic and leukopenic reactions. Hyperlipidemia is commonly seen in patients receiving sirolimus, and the findings are hypercholesterolemia and hypertriglyceridemia. So you might have to, in a patient that's on chronic therapy with sirolimus, put them on, for example, a statin. Mouth ulcers have also been associated with the drug, and they appear to be more pronounced with the liquid formulation. Other adverse effects reported include elevated LFTs, lymphocele formation, hypertension, rash, acne, diarrhea, and joint disorders. Sirolimus is effective as maintenance therapy for preventing acute rejection of solid organ allografts in combination with corticosteroids, cyclosporine, or tacrolimus. All right, other cell cycle inhibitors include everolimus or Zortress. That's the brand name. And the other name for this is Afinitor. All right, there are two brand names of this particular agent. So this drug is used in combination with cyclosporine and corticosteroids to prevent acute rejection of heart transplant recipients. Plasma levels have to be monitored carefully, and there are frequently reported adverse events, and the most common are going to be hyperlipidemia and peripheral edema. Less common but more serious include things like angioedema, proteinuria, and you oftentimes see angioedema and proteinuria being more common in patients who are on this particular drug status post-renal transplant. Biologic agents include things like surface molecules. Actually, let's go back here. So surface molecules that serve as binding sites for RATG include the T cell antigens CD6, 16, 18, 38, 40, 58, and others. And the result is inhibition of cellular function of other cell lines, including monocytes, thymocytes, natural killer cells, leukocytes, and dendritic cells. Polyclonal preparations cause a high incidence of febrile reactions with the first few doses. The most troublesome adverse effects is myelosuppression, which is manifested by leukopenia, anemia, and thrombocytopenia. These effects are dose-related, and so if you get a patient that develops them, we can decrease the dose or discontinue the drug, and this typically will go away. Other adverse effects include anaphylactic reactions, hypotension, urticaria, and serum sickness, particularly with equine ATG therapy. And we typically use that as last-line agent for patients who are steroid resistant. And remember, like I said before, about 5% of your allograft recipients are going to be steroid resistant. So these biologic agents are really going to be reserved for patients who are steroid resistant. After administration, OKT3, which we don't really use anymore, binds to the CD3 receptor, opsonizing the cells and promoting their rapid removal from the circulation. After the first 1 or 2 doses, within about an hour, pro-inflammatory cytokines are released by opsonized lymphocytes, leading to clinical findings reminiscent of severe sepsis. So there's a first dose effect, which is frequently associated with things like fever, chills, sweats, tachycardia, nausea, vomiting, diarrhea, bronchospasm, pulmonary edema, and fluctuations in blood pressure, either hypotensive or hypertensive events. Now, those events can be ameliorated if the patient is pre-treated with 1 gram IV methylprednisolone about 15 to 60 minutes before giving that OKT3 infusion. Pre-medication also includes things like antihistamines like diphenhydramine and acetaminophen. Anaphylaxis occurs in about 1% of patients, and a skin test or test dose is recommended before patients are started on OKT3 therapy. Again, I don't believe we use that therapy anymore in the United States. Patients who produce very high antibody titers, probably about 5 to 20% of those receiving OKT3, will fail to respond to subsequent doses of the drug, even when the dose is increased. Because of the risk of severe pulmonary edema, fluid status should be evaluated if patients weigh more than 2% of the usual body weight, and diuresis should be considered before proceeding with OKT3 therapy. Septic meningitis has also been associated with this drug, and it usually occurs about a week after initiation. Common symptoms obviously are going to be things like fever, headache, and photophobia. This phenomenon appears to be self-limited and may be related to the release of those cytokines early after administration of therapy has begun, I should say. The potent suppression of T lymphocyte populations is associated with an increased incidence of viral infections and lymphoproliferative disorders, and it's again reserved for therapy in terms of patients who are resistant to steroids. All right. Again, like I mentioned before, I'm almost positive we don't use this in the United States anymore. I won't ask you any questions on OKT3, I promise. Okay, so dosing strategies for anti-interleukin 2 receptor monoclonal antibodies begins with administration of the first dose, which occurs before the transplantation procedures. And these agents are effective in preventing acute rejection after transplantation. However, they are ineffective for reversing acute cellular rejection itself. Both drugs are well tolerated, with no difference in adverse effects reported in clinical trials between the drugs and placebo. And these are the drugs here: daclizumab, I don't know how the hell you say these, basiliximab. They have reported beneficial effects of reducing delayed graft function and delaying calcineurin inhibitor use. So good news is we can use some of these biologics in terms of reducing the amount of reliance on cyclosporine or tacrolimus, which is going to be more associated with nephrotoxicity. So these agents can improve outcomes. Okay, Limtrada or Campath there are two brand names for this particular drug, is a humanized monoclonal antibody directed at the CD52 antigen. It causes complete lympholysis or lympholysis, resulting in significant T cell depletion. So in other words, it lyses the white blood cell or the lymphocyte. There are significant adverse effects associated with this, unfortunately: rigors, hypotension, fever, shortness of breath, bronchospasm, and chills. There are things that we can give prior to administration which can reduce some of these adverse effects, things like acetaminophen, corticosteroids, and use of diphenhydramine or Benadryl. Other adverse effects noted include neutropenia, anemia, thrombocytopenia, and pancytopenia. Rituxan eliminates B cells by complement-dependent cytotoxicity and antibody-dependent cellular toxicity. So in relation to organ transplantation, Rituxan has been used to treat post-transplant lymphoproliferative disease, decrease presentation to blood group or HLA antigens, and treat antibody-mediated rejections. Again, I don't know enough about this particular drug or this particular area of practice to give you some great expertise opinion on these drugs. All I know is that I want you to at least be familiar with some of their general uses. All right. So what do I need to know for the exam, Dr. Blackwell? Because that is a lot of crazy questions that could come from some of that, right? Well, what I would know, guys, are commonalities. I'm not going to get into explicit things in terms of your exam for this particular unit, okay? 20 questions of your exam is going to come from Unit 5, which is solid organ transplantation, and 20 questions are going to come from Unit 6, which is your end-of-life patient family involvement in directives lecture, okay? So know the generalities, know how to interpret a hepatitis panel, for example, know the different serosubtypes of hepatitis, which we learned in the first lecture, know what the signs are of the more serious signs of rejection versus complications. Right? We said there are technical complications that can occur from organ transplantation, for example, in the liver. How do we identify those versus rejection, right? What's the normal course that a patient should take after a successful allograft is provided, right? An appropriate therapy is provided in terms of immunosuppression. And then what are signs that the immunosuppression is causing adverse events? So we talked about some of these agents. What are some of the adverse events that they present with? We looked at, for example, anemias and aplastic anemias or agranulocytosis as very common in most of these events. Most of these agents. So know how to be familiar and recognize adverse events associated with these drugs. Thank you very much for your patience and your time. That is the conclusion of Unit 5, Solid Organ Transplantation. We have involved your nursing librarian to provide some amazing resources for you on the course website. I would encourage you to read those things. They might help things make better sense than just this lecture and just the reading in your textbook. So I would encourage you to take a look at those supplemental readings. I think you'll find them helpful. Again, my name is Dr. Christopher Blackwell. I'm an associate professor and acute care nurse practitioner and the program director of the AGACNP programs here in the Department of Nursing Practice in the College of Nursing at UCF. Hope you have a wonderful day. God bless. Bye-bye now.